Okay, good morning everyone. Today we will have our second case presentation session. We have like maybe one or two cases. They are nice and would like to discuss them with you. Uh, First of all, let's start with this gentleman. He is around 50 years old, male patient, presented with jaundice. Uh, يعني it's not acute jaundice, subacute presentation, loss of weight, some fatigue, and things like that. So, first of all, Zainab, what's this exam?
CT scan, axial,
Axial.
abdominal with contrast, oral and IV contrast.
Excellent. Again, what do you use for oral contrast? What do you use as a contrast?
Water flow, soluble contrast.
Water soluble. This is for CT scan. You use water soluble or barium?
Variable artifact,
Good. You don't use barium. You use
Castography.
water soluble or low osmolar contrast medium at a concentration of get how much the concentration you remember
1 to 2 milligram per
1 to 2 milli لا, this is the dose.
C.
The dose is how much
1 to 2 milligram
milliliter
milliliter.
per kg. concentration of ايش قد الكونستريشن الموجود عندنا بالاي في contrast 300 350 370 يعني something up to 370 قلنا available. هاي الكونستريشن والدوز. الانجكشن ايش قد speed rate of injection يعني من يجي يعطيك contrast how much he should the technician give
1 إلى 2 per second. Slowly هو.
1 إلى 2 per second. هذا مو slowly, هذا fast. 1 to 2 milliliter per second يعني قصدك هذا very fast. You use 2 3 milliliter per second for routine CT scan. For angiography you increase the dose up to how much
5.
up to 5 قلنا 4 maybe 5 for CT angiography. Get it زين. الاورال كونتراست ايش قد الكونستريشن مالته يعني من تجي تطيشر بها راسا على تفتحين you open the bottle and make him drink or you dilute it or how much
15 ml per liter.
you use about concentration 3 2 3 4%. okay يعني if you have a 1000 milliliter you use like how much
15 ml.
20 30 milliliter بالليتر. okay otherwise if you give him إذا يعني بدون not diluted شو راح يصير what will happen
Artifact concentration.
it's very concentrated dense contrast will give you very strong artifact. what's the name of the artifact شو راح يصير sorry streak artifact exactly beam artifact streak artifact whatever something dense مثل كأنه واحد metallic bullet for example تطلع dense artifact. okay anyway good. So this is regarding the part 1 images. Now I will just scroll fast for you and let's see what is going on. So first of all let's have a quick look on the anatomy. You can see here there is the liver, okay, and this is the spleen, and you can see this is okay, and this is the stomach, and you can see this adrenal gland, and this is the other adrenal gland, the right kidney, the left kidney. What else you can see? Okay, you can see what else. This is the ascending colon, the descending colon. Okay, I'm intentionally leaving the pathology now for everyone to see everything, and this is the urinary bladder. Okay, so Ariane, what do you think is the primary pathology here? What do you think is going on? I'm just scrolling.
First of all, there is the dilated intrahepatic and extrahepatic bile ducts.
First, for those of you who didn't see, these are the intrahepatic bile duct or biliary tree bile ducts. You can see the arteries are contains contrast, while the biliary tree are dilated without contrast. They are hypotenuse. Exactly. Okay, continue please.
With
livers enlarged. Okay, hepatomegaly possible.
and
Media. مش قلنا معودة.
at the side of head of pancreas.
Okay, what's going on here?
There is an irregular defined mass,
Oh.
hypoechoic mass,
Hypoechoic.
hypodense,
Okay, hypodense mass.
with surrounding fat stranding.
So there is this mass here. Okay, where is it located? Basma? What's this? Where is located? Where is it located? I'm asking anatomy.
Pancreas,
In the head of the pancreas, exactly. Continue, Sitarian.
located in the head of pancreas, continuous calcification, and with the surrounding fat stranding, irregular outline.
Mhm.
Can you scroll?
So, if you notice, there is a mass here at the region of the head of the pancreas. This mass is appears a little bit rounded, maybe slightly oval shaped. It is irregular, maybe some speculated outline. It is hypodense, heterogeneous contrast enhancement. It is not, if I make it hard window a little bit, it's not a homogeneous contrast enhancement. It is located at the head of the pancreas. You can all see what is this structure. Now, Nari. What's this? This white thing. This is pancreas. Can you do you agree? What's this? We said this is what? The mass where is? So where does medial to the head of the pancreas? Or on the right side of the head of the pancreas, let's say. Sorry? Duodenum. Exactly. Second part of the duodenum, to be specific. So this is, and it contains oral contrast to confirm that it's a bowel. Second part of the duodenum. Okay. And there is a mass here measuring, I don't know, maybe 3-4 centimeter. Who cares? Okay. And if you noticed, this is the pancreatic duct. Can you see? It's dilated. Why is dilated? Because it's obstructed. So this is the first thing. Second, if you see this, we'll see it even better in the coronal images. Just okay. You can see the distended gallbladder. It's markedly distended. However, no distinct stones is seen. But the CT scan is not a good modality for gallbladder stones. For kidney stones, it's perfect. But for gallbladder stones, it's not good. You go for ultrasound. By CT, there is no stones, okay? And you can see the common bile duct, this one here, it's markedly dilated. It's measuring, I don't know, maybe 1 centimeter, maybe 2 centimeters, okay? Markedly distended gallbladder, CPD. So let's go back to the coronal reconstruction images. You can see here, this is the common bile duct. You can see it's so much dilated. And you can see this is the pancreatic duct, also dilated. Okay. And you can see this is the mass that I'm talking about at the region of the head of the pancreas. And what's on the right side of the head of the pancreas? Sorry? The second part of the duodenum. Yeah, the wall of the duodenum, of course, here it's thick. Why? Because most likely this mass is involving or invading the medial wall of the second part of the duodenum. Okay, so overall this indicates a case of what? CA pancreas, which is adenocarcinoma of the pancreas. طبعا pancreatic carcinoma is an adenocarcinoma. Okay.
The most important thing is to look at vessels.
Exactly.
Related or not.
Exactly. The very important thing here to write in your report is to write whether the arteries and veins surrounding the mass are invaded, encased or not. Why? Because this will tell them if it is operable or not. Okay? So, again, let's go in.
SMA
We will evaluate.
reserve.
Yeah, we will evaluate it together. Just give me a second.
And look for liver if there is any
Sorry.
metastasis.
Yeah, sure. طبعا we should look for metastasis, of course. So, first of all, خلينا نشوف شنو What is this vessel? Celiac artery, exactly. Wa'ad, what's this? Common hepatic what? Common hepatic artery. And what's this? سبلينيك ارتري. طبعا حلو انه قلت لكم انه بليز لحد هذه بس الكل ده يجاوب على الشيء اللي قاعد اسال صاحبي الكل. اوكي يعني مو انا ما دا احكي عليك دا اقول على الكل. اوكي so I'm not liking that صراحه يعني. So قلنا this is the celiac bifurcating into hepatic, bifurcating into splenic. Okay, and what if I go inferior to it? What's this directly? What? Superior mesenteric. Exactly. So we have طبعا أهم شيء the superior mesenteric to evaluate its relation with the mass. Okay, so see this superior mesenteric, this dot, white dot, and see the mass. There is a black line separating it from the mass, and this black line is سمر مو صح؟ سمارة. What is this black line? What does it indicate? شنو black هذا بالسي تي؟ شنو يعني؟ fluid. Do you agree? اي لا شنو؟ fat. شنو شو تقولين؟ fat. So the black, this is a fluid, a bile in the biliary tree. This is a fluid, CSF in the fecal sac. Fluid is not black, it's gray, this color. I don't know what you call it on the CT scan. What's black? You have this black, which is air, and this black, which is fat. Okay, so just let me adjust the window a little bit. This is fat, this is air. Okay, so as long as there is a plane of fat between the vessel and the mass, indicating this vessel is not involved. Okay, if the fat plane is lost, now we are questionable. Can be involved, can be not. If it is encased, it is involved. If it is compressed, it is involved. If just the fat plane is lost for less than 180 degree of the vessel circumference, you are in between. Maybe yes, maybe no. More than 180 degree, the probability of invasion is more. But 100% involvement, you cannot know.
Yes.
Okay? So, the SMA is not involved. You have to write that in your report. And now, let's see, Iman. What else other than the SMA we should look for in this case for invasion? Portal vein. Excellent. So, this is the portal vein. Okay, maybe I think this is a venous. No, this is not a venous face. This is delayed. Well, it can serve, not very much delayed. Anyway, so this is the portal vein. Okay. Do you think it's involved? I will try to adjust the window a little bit. Do you think it's involved, this portal vein? It has no relation to the mass. There is this fat plane here. It is not in contact with the mass. It is not involved by the mass. Okay? So this is the mass. This is the inferior vena cava. This is the aorta. Do you think the IVC is involved? There is just this tiny area of lost fat, which can be or cannot be invasion. You don't know. You have to just report this area. قول عيني. No. No. Preserved fat plane. It is separated. Indicating if it is 1 millimeter, if it is 10 centimeter, it indicates that this artery or this vessel is not invaded by the mass. Okay? زين. منو جماعة البرايمري هسه اللي بالشين؟ Portal vein composed of what? نارين. Sorry? Splenic vein and superior mesenteric vein. Exactly. They unite where? Behind the neck of the pancreas. Exactly. So we have this is the splenic vein here. Okay. Uniting with, let's go down. Sorry, let's go down. This is the superior mesenteric vein. Uniting with each other at the region of the neck of the pancreas. We said the mass is in the head, so this is the neck. Okay, here if you can see, this is the inferior mesenteric vein also joining them joining the, sometimes it joins the superior mesenteric vein and then joins the splenic vein. Sometimes all three of them join together. Both of them are normal variants. Okay? So, painless jaundice equals, you know, CI pancreas. Keep in mind. Painless jaundice, most of the times will be CI pancreas. زين. هسه أنت أثناء scrolling you've seen something no one talked about while we were scrolling, something interesting.
In this area?
لا مو بهذا يعني أثناء السكرولينج كله. You've seen something, anything caught your eyes? Okay, media. دقيق. Sorry? You didn't catch. يعني ما أجاب عينك خلينا نقول. قولي عيني يا ريان.
The water phase of the stomach.
No. انت تعرف انت لا تصير عضلاتك هذه انت ريبورت يمك. زين. Anybody see anything? Huh? Not in this image. I mean scrolling all over.
Next time.
No problem. Okay, I will scroll just hit rapidly and wait يلا خلاص. What do you think is going on here?
I saw it.
يراد ليش ما قلت لي وايد صار لي ساعة.
Yes.
There is a mass in the left hilum.
But I think
Surprising. Surprisingly, it was accidentally seen during CT of the abdomen. The patient request was CT of the abdomen. Okay, and just the technician wanted to be a little bit extra cautious. He took a little bit of the chest. Okay, and in the chest there is this mass. Okay, and let's change it into lung window. Okay, you can absolutely evaluate. Just that even not the whole mass is visualized. It's just this is the tip of it because it's أصلا abdomen CT يعني زايد من عنده إنه طلع الchest. Okay, there is this speculated mass here at the left hilum, which is I don't know to be honest, which is invading the adjacent vessel, the pulmonary vein. Which one is the primary? Which one is the metastasis? Don't know. Are they two primaries? And then again, it's possible. Okay. So I really didn't have the diagnosis till now, but if I have any update, I will tell you. Okay. So it's an interesting. I think I'm with you. It looks like two primaries, which is unlikely and very very bad luck for him, but it happens every now and then. Okay. Any questions on this case? قول عين. And this is the mass invading the duodenum, and you can see this is the pancreatic duct that's dilated, and طبعا the head you cannot see it properly because it's replaced by the mass. Okay, and since the mass is in the head, invading the region of the ampulla of water, causing dilatation of the common bile duct and the pancreatic duct together, and then you have here the neck and the body and the tail of the pancreas lying at the region of the splenic hilum. Okay? Good. So.
There is no gas in the biliary or
No bile, not gas. Sorry, I just pulled the CD. But it is bile, not gas. Okay? Because there is the ampulla of water is invaded, obstructed, so gas will not be there. Okay? Good. Now, something rather interesting. Let's see if this loads. Isn't it time? We have time. I'm not sure whether it will load or not, but we will see. So, just give me a second, please. Okay. This is a 50-year-old male patient. Okay? Presented, he was absolutely normal, not complaining of anything. Okay? some mild unrelated epigastric pain. They did an ultrasound. They recommended a CT scan. He's healthy. Okay. Not complaining of anything again. He has a previous surgery long time ago, which he does not remember for what. Okay? He's a diabetic with a little bit elevated renal function tests, so IV contrast was not given. Okay? It's a CT scan of the abdomen with only oral contrast. Okay? No IV contrast, which this part is the thing that makes it difficult. Okay? So, we did a CT scan according to the ultrasound recommendation. What do you think is going on here? Multiple liver lesions. Okay. I give you the whole history. That's all what I know. Yani. By ultrasound, they saw multiple liver lesions. Recommended CT scan to confirm or exclude, or to confirm metastasis. Okay. So, you can see there is some calcific focus here. You can see this is a hypodense mass, another one here, another one here, another one here. There are multiple, another one here, another one here, okay? Again, he's 100% healthy. Tamam? First of all, he reported previous abdominal surgery long time ago when he was young, and he does not know for what. What do you think is the surgery? Exactly. Hydatid cyst surgery. Where was the hydatid cyst surgery? In the liver. There is a lobe removed. Excellent. Good. Excellent. There is a lobe that is removed. Which lobe is that? The left lobe here, you can see, is removed. Okay, it's not present. So, and the calcification is most likely what? Surgical. No, this is not surgical. This is within the liver. These are some clips and sutures and things like that. Okay, so where is, he has multiple liver metastases. Where is the primary? Let's go back to the axial. Sorry? Nothing is approved. We are discussing the case like it's here. Okay, that's like it's arrived. Patient, healthy, diabetic, elevated renal function, previous surgery for hydatid cyst by left lobectomy, old, very old, okay, presented with multiple hypodense and hypoechoic liver lesions. On ultrasound, hypoechoic solid masses.
Simple?
No, solid masses.
Solid, yeah.
Okay? Well defined. They are big, they are multiple, so relatively well defined. Okay? So I will scroll and maybe a little bit adjust the window.
Come on, first.
Okay, search. This I will scroll it and tell me if you see anything abnormal.
We should give the body a name.
Yeah. So you can see the colon here is very nicely demonstrated. It is not full. It is very, this is the, I will scroll with you. This is the area of the rectum, and then we're going to the rectosigmoid junction, and then you look for the descending colon. Okay, this one here, let me try to, this one here, this is the descending colon. There we are going for the what? Transverse colon here. It looks nice, no masses, no stranding of the fat planes, no surrounding lymph nodes. And then here's the hepatic flexure here. And then you go for the ascending colon, the cecum, sorry. Okay? And here is the ileocecal junction. Okay? A little bit, this is the appendix, is very nicely demonstrated here, which is within normal and it is not inflamed. So, up to 20 centimeters is normal. Anyway. So, these are the small bowel. They contain oral contrast and they are not dilated and no signs of bowel obstruction. Kidneys look good all over regarding the size. Sorry?
It's normal.
This is acceptable, okay, especially in the older age group. And So we don't have any lymph nodes, we don't have any ascites, we don't have nothing, okay? So what would you like to do? Media. Next step. MRI. قبل الMRI قول.
Laboratory investigation.
Laboratory. Like what?
Eosinophilia. They have blood and complete the picture.
He is not complaining of these masses. He has nothing. He's healthy, wealthy, coming, not complaining of anything. He's coming.
IgE with eosinophil.
Okay.
Anyway, goes with hydatid.
Okay, we know that he has previous surgery for the left liver lobe. 99% will be more for hydatid. So these are solid lesions by ultrasound. Biopsy. So you would like to biopsy someone with possible hydatid cyst?
Now they said that it's okay to do biopsy for these lesions.
Well, I will never do that, even if they say it. When the patient comes to you, you do it. I will not do it. Because why? If it's hydatid and it's ruptured, it will seed. The patient will go into anaphylactic shock. If he survives the anaphylactic shock, he will have hydatids in everywhere in his abdomen. It's worse than cancer. Never do a biopsy for even suspected. I don't know whether the new guidelines say different thing, but I mean, no one is crazy enough to do that.
So you said this is solid.
Yeah.
Excluding hydatid.
Wow. No,
اوكي هسه ما حد اعطاني فكره اللي ممكن يعني هو نون هايداتد راح يطلع اي جي اي بوزيتيف راح يطلع ايزنوفيليا راح يطلع كل السؤال وي نو ات بريفيوسلي chest x-ray okay we cannot it was slightly elevated renal function diabetic so I could not give him the IV at the time of imaging يعني I didn't have time to prepare him sorry PET scan wow it's too much just put the Doppler signal put a Doppler if there is internal vascularity it's not a hydatid if there is no internal vascularity with the okay if none of these big lesions none of these multiple big lesions none shows any internal vascularity you have a very strong suspicion of hydatid okay and I took the patient put an ultrasound put the Doppler even though these lesions are so big and so multiple okay for example this one is I don't know 5 centimeter maybe almost 5 centimeter diameter sorry Hounsfield unit let's see Hounsfield unit where is the ellipse okay ellipse Hounsfield unit and we have mean of 24 25 something like that okay soft tissue density maybe thick fluid okay by ultrasound it was a soft tissue echo pattern hypoechoic طبعا little bit heterogeneous okay but no internal vascularity at all in none of the regions ولا واحد ولا شعرة vessels okay he's completely normal so the possibility of having a hydatid cyst is very high especially with the previous history of left lobectomy due to hydatid cyst and followed up طبعا biopsy was contraindicated in this case followed up for I don't know maybe 2 years now and it's everything is stable sorry
by medical treatment
best follow up nothing there's nothing to be followed to be treated
the lesions were
stable in size and shape and diameter and the patient is doing perfectly well okay so the question is which stage is this hydatid stage 1 2 3 4 5
before classification 3
before
4 is classified
1, 2, 3 active.
this is what's called the pseudotumor stage which is stage 4 okay this is called pseudotumor and I think obviously why it's pseudotumor it's very much look like طبعا contrast here is very IV contrast. It will be very helpful because these will not enhance. They are just dead cysts. Okay, some peripheral.
On ultrasound also we can see the 3 layer of ectocyst.
If it was in the cystic stage, this is a pseudotumor stage. It's now solid. Okay. Okay, let's have one more case, and I think we'll stop here. This is a rather recent case, and since we are talking about the last few weeks, we talked extensively about calcifications on mammogram. I think we should have a case of mammographic. So, this is, I think, maybe 60-year-old female patient presented with right breast swelling, edema, thickening, and things like that. No palpable mass. It's been like that for maybe 2-3 weeks. Okay. For mammogram and ultrasound. Okay. I did the mammogram. Dr. Jalal did the ultrasound. Anyway, just give me a few minutes for the imaging to load, and let's see what will we have. Okay. First of all, Dr. Mediani, this is the left side. Okay, let's start with the left one. What is going on here?
Vascular calcification, in addition to variable size geometry calcification distributed in the
I will try to magnify things for you.
calcification in the direction of the left.
There are linear calcifications in the direction 67, okay, in the direction of the ducts of the left breast, okay. You can see this interrupted lines and thick with sometimes with a lumen within, very suggestive of vascular calcifications as we discussed in the mammographic calcifications, right? Lectures, right? Again here, these are in the early stages of development. These are mature calcifications. We have different stages of calcification. Okay, let's see the right side. What about the right side? Come on, load, please. Okay. For the first look, what do you think is going on here?
Increased density of all the breast with increased skin thickness.
So, there is diffuse skin thickening, if you notice here.
Contradictory.
Just wait. Let me. You can obviously see the marked skin thickening and edema all over the breast. Okay? Now, and what are these? Again, vascular calcifications. What else?
Increased density of the all breast with coarse radiculi.
Okay, just maybe if we can put two images together, maybe to help comparison. Just let me see. We need to make them together. You can obviously see the density of the right side is increased compared to the left side. Why it's increased? The whole breast, because it is edematous, okay, as part of the skin thickening, okay. Vascular calcifications, yeah, it presented with right breast thickening and swelling.
Differential diagnosis.
So,
Differential diagnosis for edematous breast different if it's unilateral or bilateral. If bilateral, we should think something systemic.
هسه unilateral. We have
Unilateral.
okay.
Nipple also, I think it is somewhat.
If you compare the right side with the left side, the right side is maybe a little bit retracted. So,
Lymphangitis, inflammatory carcinoma.
inflammatory carcinoma.
For differential diagnosis. Or if the patient have history of radiation.
No history of radiation. No previous breast intervention. This is first
or
presentation.
Sometimes even infection.
She doesn't have a previous mammogram, by the way.
Infection.
Mastitis is a
Infection,
possibility.
inflammation is-
Okay. Which one of these differential diagnoses you think is the most probably?
inflammatory carcinoma.
Huh? Mastitis. Do you think mastitis is common in 67 years old? I mean, there is no breastfeeding, there is no trauma, for example, there is no scar, no nothing, okay, to suggest mastitis first. Second, mastitis will most likely present focally, not the whole breast. Can present those, I'm not saying no, but it usually will present in a more focal distribution, okay? So, in a 67 years old, inflammatory carcinoma will be much more probable than. So, now we need to look for clues to direct us either to here or to here, okay? Ultrasound done and showed just edematous breast, no masses, few axillary lymph nodes of no يعني شو نقول particular shape.
Skin pinch biopsy should taken.
No biopsy done, or يعني at least till the لاحظوا يعني till the mammogram there was no biopsy. Before the biopsy, there is another clue here that no one commented on.
There is artificial distortion.
Okay, we said trabeculation. Yeah, we said trabeculation. What else?
The technique is
Okay, maybe I think the viewer has some little something to do with it. Anyway, I will help you. Let's see if we go for just a sec. Let me magnify it. Maybe we can see something here. What do you see here?
architectural distortion.
There are pleomorphic, variable size, variable density. Wait a second. Give me 2 minutes, okay? First of all, we have pleomorphic, different shapes, different sizes, different densities, micro calcific foci here and there. In addition, high vascular calcification, okay, we are okay. In addition to the vascular calcification, they are of a regional distribution here. They are not present here. Do you see? On the outer aspect, it's not present. It's present in the medial aspect, okay? It's in a regional distribution, pleomorphic, variable size, variable density, variable shape in a localized manner in a 67-year-old with the breast thickening with two differentials, mastitis or inflammatory carcinoma, with no old mammogram to confirm and no mass on ultrasound. Okay, so this microcalcification give you a BI-RAD what? 5. Okay, at least 4C, يعني, at least. And now we should recommend a biopsy, punch biopsy. Okay, because on ultrasound there is no distinct mass. Either you do it blindly or you go for surgical. Let's
Like you can't put a wire for guidance.
yeah, okay, you can't put a wire.
Because there is no mass. To
Exactly.
The wire in this case.
A wire will be very helpful. And should I go? Sorry, I forgot. Anyway,
Compression, you said? You mean compression? You can do compression.
of course, compression magnification reviews and spot compression reviews, of course, they are all helpful. So you can see these calcifications are in a very rather regional or segmental part of the breast. These are very suspicious and accidentally on the same side of the abnormality. It will never be like that. These are microcalcific. You can see here there's nothing apart from the vascular calcification I'm talking. Okay? So this indicates that high probability of inflammatory carcinoma. We are waiting for the results of the biopsy.
There is also a architectural distortion if you compare upper to lower part.
Let's see architectural distortion. If we compare the and this, by the way, on the CC view, were on which part of the breast? On the inner, which is a very uncommon location and very suspicious location. one of the other things that support the possibility of malignancy. You can see, compare the upper part of the breast with the lower. This is a MLO view. The upper part with the lower part. Of course, there is some increased edema, some more architectural distortion in the lower part of the breast. Okay?
It could be another possibility. Invasive ductal carcinoma.
Invasive
with,
duct-
lymphatic
Obstruction, invasion.
causing this edema.
Again,
Also.
it's possible. Invasive ductal carcinoma is a possibility. But usually, at this stage, invasive ductal carcinoma will have a mass.
Yeah.
Usually, not always. No mass by a mammogram, no mass by ultrasound, no mass by clinical examination.
Clinical, is there any bloody discharge or any?
Redness and pain and things like that.
This goes with the
Of course, there is pseudorange. It's edematous. Definitely will be. Okay? Thank you very much. See you next week, inshallah.